I think I'll go ahead and get started with introductions for tonight, while we're allowing other people to log on. Let's see if I can share this. All right. So just a reminder, I know we do JVS Journal Club every month, but about a year ago, the SVS Young Surgeon Section Research Committee started with this initiative of doing a Young Surgeons Section sponsored JVS Journal Club. And so everyone involved with tonight's Journal Club falls within the Young Surgeon Section category, which is trainees or anybody within their first 10 years of practice. And that includes all the senior authors, the discussants, the moderators, everybody. So we're really excited to feature some of the great early career surgeon scientists in the vascular surgery world. And I encourage any of you on here that are eligible for the Young Surgeon Section to sign up, because there's some great opportunities for you in that section within SVS. The two papers we're going to be discussing tonight are challenges surrounding hemodialysis initiation faced by undocumented immigrants and validation of non-home discharge risk score after elective infrainguinal bypass surgery. And I guess I should introduce myself. I'm Libby Weber. I'm an assistant professor of surgery at the University of Utah, filling in for Dr. Humphreys tonight. So our presenters for tonight will be, for the first paper from the University of Chicago, Dr. Ashley Williamson, an assistant professor of vascular surgery, and Dr. Yu, one of the vascular fellows at the University of Chicago. And then from Northwell Health, presenting our second paper, will be Dr. Silp, who is also an assistant professor of vascular surgery currently in the OR, but hopefully will be with us shortly, and Dr. Yu, different Dr. Yu, vascular resident at Northwell Health. And our authors here with us tonight to participate in the discussion include senior author Dr. James Iannuzzi and medical student Dr. Raby from UCSF. And Dr. Christopher Ramos from Emory is the senior author of actually the first paper we're going to be presenting, as well as we hope that Dr. Ramazani can log on. She is currently an intern at the University of Washington in Seattle, so she's on a little different time zone and probably in the OR still. Hopefully she'll be with us soon. And we have two special guests to lead the discussion for these papers tonight. Dr. Carla Morara from Brown University, an associate professor of surgery, will be leading the discussion for our first paper. And Dr. Amber Kernodle from Brigham and Women's will be leading the discussion for our second. Dr. Kernodle is currently a vascular fellow, but about to finish her fellowship and staying on staff at Brigham and Women's. So with that, I will, a few reminders, sorry. Please stay muted during the presentations and discussion. We do allow for participation during some of the discussion, but if you have questions, submit those questions in the chat box and we will help moderate those. The moderator may call on you to ask your question or participate in the discussion. This event is being recorded so that it can be available on demand following the event. Please remember to join us for our next JVS Online Journal Club, which will be Wednesday, August 13th at 6 p.m. Central Time. The host for that will be the University of Alabama and Michigan Vascular Center. And all future dates for 2025 are posted at vascular.org. It's always the second Wednesday of the month at 6 p.m. Central Time. So with that, I will turn it over to our first Dr. Yu. From the University of Chicago to get us started with the first paper.
Gotcha. And Libby, you want the intro real quick, yeah?
Yes, I'm sorry, Dr. Williams.
Yeah, you're totally fine. No worries. So thanks for hosting us. Yasong and I are thrilled to talk about this. We practice in a area that has several undocumented immigrants and high access to care on the south side of Chicago. And so we were thrilled at the opportunity to discuss this. I won't say this about every fellow we put on here, but Yasong is a rising senior fellow and is outstanding and is about to start the job hunt. And we are going to try and retain, but is readily eligible for anyone who is out there. So this paper is really interesting to me, but I think any of us who practice in really any area, but certainly in urban areas, see these patients. And when we get undocumented immigrants coming into the ER, most of the time they are patients who require emergent dialysis and who have never been evaluated by either a nephrologist or a vascular surgeon. And so I think that discussing this problem is really the first way to kind of access and identify how to address it. And so when we look at kind of the clinical problems and gaps in this paper, I listed just a few because I think your song is going to go through quite a bit. But number one, we have pretty minimal knowledge on vascular access in this patient population because we don't have much access to knowledge on pretty much anything medically. But we know that they're at increased risk for needing dialysis because of their increased medical comorbidities and access to care issues. We don't have a good understanding at all of the timing of evaluation by nephrology or vascular surgeons for access, which this paper very clearly identifies. And we know that obviously catheters have increased risk for infectious complications. And while we could probably deduce that these patients end up with catheters more often than not, we really don't have a good understanding of the increased incidence of this in the undocumented patient population. We lack any long-term outcomes in this patient population, and we don't understand where the delays occur. Do they occur at every level? Are they at a time to initial evaluation or time to surgery? This paper identifies one of these gaps that doesn't exist that Yasong's going to highlight, but I think is an interesting knowledge, particularly for vascular surgeons here. And then further, we really don't understand the long-term costs to the healthcare system or patients. And I think, sometimes this is a politically charged issue, but when you look at each of those systems, right, healthcare system and to the patient, I do think that earlier access to dialysis creation and access creation could really help with risk reduction. So Yusong's going to do the more in detailed presentation, but those are kind of the gaps that we're going to address.
All right, can everyone see my slides? Okay,
Yeah, you're
perfect.
good.
Awesome. So thank you, Dr. Williamson, for the kind words and the introduction. My name is Yasam. I'm a first-year fellow, soon to be second year at University of Chicago. And today I'll be talking about a paper on a very important topic, I think by Dr. Ramazani and Dr. Ramos' group. Originally was done in Atlanta, Georgia, out at Emory. And it is titled Challenges Surrounding Hemodialysis Initiation Faced by Undocumented Immigrants. So quick introduction, end-stage renal disease or advanced chronic kidney disease patients, they often get sent to nephrologists initially for their hemodialysis planning. And from there, they're generally referred to vascular surgeons, so that's us, for access creation. However, in patients that are undocumented immigrants who have end-stage renal disease, they face many challenges in getting to hemodialysis. Some of that most of it is from access to healthcare, but a lot of it stems from their exclusion from Medicare coverage, Affordable Care Act, and most state Medicaid programs. Currently, 30 states do not offer coverage for standard outpatient hemodialysis for undocumented immigrants. So what do these patients end up doing? They end up going to the emergency room for emergency dialysis when they need it. And in these circumstances, there are data out there showing that these patients have worse outcomes compared to their standard dialysis patient counterparts. These emergency dialysis procedures also have a very high cost and puts a strain on the healthcare system. On average, it costs about $285,000 to $400,000 per person per year versus less than $100,000 versus their standard dialysis patients. And they also get a lack of referral to vascular surgery since they have poor access to seeing a nephrologist to begin with. So the hypothesis of this paper I'm about to present is that the undocumented patients with end-stage renal disease would have a delay in referral to subspecialty services, leading to delays in arteriovenous access creation and more extended dependence on central venous catheter use, which also leads to a higher prevalence of catheter-associated complications. The study is a single institution retrospective cohort study. All the patients who underwent first-time arteriovenous access creation from 2012 to 2018 were included, and the patients were then divided based on their documentation status. The undocumented patients are patients who are not born in the US, lacks Medicare and Medicaid coverage, and are not eligible for outpatient dialysis in the state of Georgia. The primary outcome of the paper is the time to initial evaluation by vascular surgery and nephrology in relation to the time of initiation of hemodialysis. The secondary outcome measured in the paper was the incidence of catheter use for hemodialysis initiation and continuation in undocumented patient population, and as well as catheter-associated complication in those patients. So the initial cohort had 415 patients, as shown here. 125 were excluded because they did not have adequate long-term follow-up, and we ended up with 290 patients. And those patients were divided into documented and undocumented patient populations. And part one of this paper really set out to evaluate the timeliness of subspecialty care in documented versus undocumented patients. And 5 main endpoints were measured. So the time from nephrology encounter to hemodialysis, first vascular surgery evaluation to hemodialysis, vascular surgery evaluation to AV access creation, AV access creation to access maturation, and hemodialysis start to AV access surgery. And then part two of the paper looks at the central venous catheter use and complications in undocumented patients. So out of the 62 undocumented patients, they were further divided into patients who received hemodialysis via central venous catheter and then later on got a arteriovenous access for dialysis, and those who purely relied on a central venous catheter. So when we look at the results, these are the patient characteristics of the 2 patient groups. And there are some differences highlighted by the p-value here. As you can see, the documented patients tend to be a little older, or undocumented tend to be a little younger, I should say. They do have different race composition. They tend to be of Hispanic ethnicity at this particular institution. Also, there are some differences in their comorbidities as well. And when we look at the primary endpoint from the time of first nephrology and vascular surgery evaluation to the time of hemodialysis, there is significant difference between the 2 groups. So in the undocumented group, as shown by the top of the table, the median days that takes for nephrology to evaluate the patient is actually on the day of hemodialysis initiation, whereas if you look at documented patients, they tend to get evaluated over 200 days earlier. For vascular surgery, they tend to get evaluated almost more than 2 months after the initiation of hemodialysis, whereas documented patients get evaluated prior to initiation of their hemodialysis. The likelihood of a pre-dialysis vascular surgery evaluation is much higher in the documented group, as well as the likelihood of a central venous catheter at dialysis initiation is much higher in the undocumented group. But when you look at purely at the patients who had already seen nephrology prior to initiation of dialysis, there's not that big of a difference in the number of days between the evaluation and hemodialysis initiation. There is a difference, however, between the days of vascular evaluation and hemodialysis days. So in the undocumented patient population, they usually get evaluated about 3 days prior to hemodialysis, whereas in the documented patient population, it's usually more than 2 months prior to hemodialysis. And that may have to do with gaining access to vascular surgery, in particular in the undocumented patient group, and they face some challenges there. These 2 graphs shows the proportion of patients that gets evaluated in the undocumented documented groups by both nephrology and vascular surgery. So in the first graph, you see that in the documented patient population, nephrology tend to evaluate them more often than not before the initiation of dialysis. And if not, all of them are at the initiation of dialysis. And the opposite is true for the undocumented patient population. When you look at vascular surgery evaluation, most of the documented patient, again, gets evaluated before initiation. If not, they get evaluated after dialysis has started. And the opposite is true for undocumented patient population. Now, looking at the AV access creation, a large part of what we do, and you can see that from vascular surgery evaluation to AV access creation, there's actually not a significant difference between the two populations, meaning that we're doing a good job as soon as the patients get through the door. We're doing a good job of getting them taken care of in creating their access. Doesn't matter their documentation status. And from AV access creation to AV access maturation, again, there's no significant difference. However, from hemodialysis start to AV access maturation days, it is significantly longer in the undocumented patient population, and largely due to difficulty of them gaining access to a vascular surgeon to begin with. Now, part 2 of the study, looking at the complication of central venous catheter, the patients are divided into CVC group, patients who are catheter dependent, and CAV group, patient who ended up transitioning from catheter to arteriovenous fistula. So in the CVC group, you can see that there's a much higher percentage of patients who end up with catheter-associated complications. At 73% versus only 46% in the CAV group. And not surprisingly, the median days of complications is much higher in the CVC group or the catheter-dependent group when compared to the CAV group. And these complications were further divided into mechanical malfunction, infection, and central venous stenosis. And this graph shows the proportion of each group within the undocumented patient population that experiences each type of complication. And you can see the catheter-dependent group has a much higher proportion of mechanical malfunction and infection. And the central venous stenosis is about equivalent between the two groups. So just a summary of the results. In undocumented patient population, they're more likely to be younger and of Hispanic ethnicity. There's significant delays in accessing nephrology and vascular surgery care, and they're more likely to initiate hemodialysis without prior nephrology or vascular surgery evaluation. And they have a higher reliance on catheter when they are initiated on hemodialysis. So at some discussion points, it highlights the importance of access to nephrology pre-dialysis, especially in this studied population, since nephrology is the first point of contact that kind of initiates the care down the line. They are the ones referring the patient to vascular surgery to get their access, probably coordinating their dialysis as outpatient as well. So access to nephrology has a very significant downstream effect. And once the patients are evaluated by vascular surgery, there's actually no difference in the time of access creation and maturation, meaning we as vascular surgeons are doing a great job at creating the access for these patients, for any patient that needs AV access. When you look at documentation status, I think it's very interesting that the paper chose this as the main highlight to differentiate patient groups. But I do think that it is something that reflects their other social determinants, probably their lack of insurance or a language barrier, poor health literacy, et cetera. The paper also highlights the financial strain that immersing hemodialysis puts on the healthcare system. So what are the solutions for this problem? I think the solution can be broken down into different levels. So on a national state level, you really need policy change, expansion of Medicare, Medicaid programs to be more inclusive, to cover patients who are undocumented and potentially need help them gain access to nephrology as well as outpatient hemodialysis. On the institutional department level, I think something that we could all do is making sure that patient has, we have good patient care coordinators that can help these patients navigate through a very complex healthcare system and make sure they get the adequate that they need. And I was just thinking on an individual level, there's always something that we can do as individuals. Me personally, when I'm evaluating a patient for maybe some other unrelated vascular problem, if there's a patient that has only a catheter and no access, maybe asking the question, what's going on with this patient? Do they have difficulty accessing, getting access to a vascular surgeon? I think small things like that could also help a lot of patients. And some of the limitations of the study is it is a single institution, single practice setting, single state, and single patient population that's specific for that institution. So it does lack a little bit of generalizability. And there's also variability between institutions in their referral patterns as well as protocols for initiation of hemodialysis, and that may affect the outcome and if the study were to be performed at other institutions. It is a retrospective study and relatively small sample size, so that may limit some of the outcome of the study. And that's all I have for this paper. Thank you for your time and attention, and I'll turn the floor back to Dr. Weaver and Dr. Morera.
Thank you so much for an excellent presentation. We have Dr. Ramos, the senior author of the paper, here with us, and Dr. Moreira is going to lead some discussion. We already have a lot of questions and comments in the chat box, so. I think she's here. She was here. Did she get kicked off? Oh, there.
Is Dr. Ramos?
He's on there.
Yes, I'm here. I can start. Thank you so much for including this paper in this journal club. As people have mentioned, I think this is a very important topic to discuss. This is if not a very vulnerable population, if not the most vulnerable population that I can think of, especially in the current political time right now. These patients can't speak out for themselves. They have to just take what they're given, and a lot of times don't have anyone to advocate for them. So what we did was we looked at our data, and we found some gaps. Obviously, it's hard to fix the timing to referral to nephrology, right? These patients just show up in the ED from other hospitals. They're sent to our hospital for to just do emergency dialysis at our facility. This study is actually out of Grady Memorial Hospital, which is Atlanta's only level 1 trauma center, but also the safety net hospital in Atlanta. So pretty much if there's an undocumented patient in these dialysis, they end up being sent to Grady. Currently, we have about 120 to 130 undocumented patients in our dialysis unit. So what we've done with this data is, because we have state funding and subsidies, we're fortunate to be able to operate on these patients, right? So we're able to treat them like the documented patients. So, as soon as vascular surgery sees them, we're able to get them through financial clearance, which isn't much. The patients end up paying like $50 copay or something, and we're able to get them through surgery. But the problem then is the follow-ups, the surveillance, the maturation, and things like that. So we were seeing that we were able to get the fistulas created, or AV accesses created, but we were losing them to follow up. They weren't following up. They still have a catheter and a fistula. The fistula wouldn't get cannulated because no one gave the permission, and so on. So pretty much what we did with this data is get institutional funding to as the presenter mentioned, to get a patient care coordinator. And the patient care coordinator has now helped decrease the time from dialysis access creation to catheter removal. So, we've successfully intervened on 45 undocumented patients since this patient care coordinator was initiated 9 months ago. And our timing to catheter removal is about 7 months now, which, if you think of it, we're doing a lot of fistulas. So, it takes a couple months to see them for fistula creation. And then for fistula maturation, takes 2 or 3 months, to get it cannulated, make sure it's working, and then to get the catheter out. So, I think we're doing okay. We can do a little bit better, but what the patient care coordinator has been doing is making sure that the appointments are appropriate for the patients. They're on non-dialysis days. They're able to make it. If they don't make it, call them. Why didn't you come? What's going on? Making sure that our dialysis unit is starting to puncture. They're not puncturing. Why? What are the limitations and things like that to help facilitate for this patient population? Our patient population is mostly Hispanics, and uh, we felt that it was very important to make sure to have a patient care coordinator that spoke Spanish as well, because obviously the patient care coordinator is going to be talking to them on a daily basis to making sure that they're able to get through. But this care coordinator has not only worked with our undocumented patients, they've also helped bring back PermCath patients that were discharged from the hospital that got lost to follow-up. So they've also brought back 50 patients that have been lost. So for the hospital, that's about $10,000 per fistula that they would make, both in the creation and the maintenance and any maintenance fistulograms that are created in the first year. There's data, showing that. So for the hospital, that's a lot of money that they can make by just paying an MA entry level salary. So, I'm trying to collect this data to show our hospital administration that it's worth, not just for the undocumented patient, but just for any catheter, any patients that already have a catheter, try and get that out as soon as possible.
Thank you, Dr. Ramos, and again, thank you for the opportunity to discuss this paper. And for me, as someone who, I love fistula creation. I love access work, and I feel like sometimes as a vascular surgeon, when you say that, it's because I do feel like sometimes it is the least sexy of all of the vascular things that we do as vascular surgeon. Access work is probably maybe not as sexy as aorta, and especially for the trainees, in terms of. But it is the area where I get to is very satisfying, because I can put on, in terms of surgeon, for the trainee, I'm like, this is the smallest anastomosis that we do. And if you can get it to work, that means that you are a very good surgeon and you are doing God's work. If you can get and you can create a fistula for this patient, it's their lifeline and so forth. So in terms of, you have to kind of have that passion. And then for also my interest in terms of advocacy, and that's where you get to put your hat on as an educator, as you're working in multidisciplinary team, and you're really mobilizing the entire health system in terms of these patients, as Dr. Ramos said, are going to be the most disadvantaged. And when you add, especially in this is a very timely and topical that we're talking about this, undocumented patients are going to be the most vulnerable in our healthcare system. That seems like it's not working for those of us that have insurance, that have access, that have it's going to be even more so for us. So I know there's lots of questions already in the chat that I want to get to, but I want to say that as a vascular surgeon, especially for the trainees that are on this, if you're interested in this topic, I think vascular surgeons in this role, especially in access work in terms of health equity and system-based implication of taking on there's opportunity for institutional advocacy in terms of engaging hospitals in terms of policy work, creating pathways. Not only can this be a model within access for your vulnerable patient, but also for other pathways. Very, again, thank you, Dr. Yu, for in terms of your presentation. And I do have some questions, but I think this was a great topic, well presented. And I want to get to some of the chat, and we'll see if they ask some of the questions that I have. And if not, hopefully we'll have some time to get to it. So let's see.
Well, your reading, I was just going to say, Dr. Ramos, I think, at least in my first year as an attending, I had no sense of how different the financial compensation was for dialysis access and how dependent upon the states it was. So in the state of Illinois Medicare system currently reimburses double for dialysis access. So there is a huge initiative in the state of Illinois to get vascular surgeons to put dialysis access in. However, we're a hospital that's right on the border of Northwest Indiana, covers all these hospitals in Northwest Indiana, and we cannot put dialysis access in to patients who are Indiana Medicaid or Medicare because the hospital and the state won't reimburse it. And so I think nationally it'd be really interesting to get a sense of what different states are like and how our hospitals are dealing with that in a struggle, because I truly had no sense of that, until this year.
And again, I apologize ahead of time if I mispronounce your name as I read some of these questions. Please correct me. Dr. Hingorami. I apologize. So this has related to, in terms of placing, giving access or AV fistulas in patients and who are undocumented as young as 20-year-olds. While this paper clearly identified that these are undocumented patients are younger, do we really need to focus on the underlying cause of why these patients end up on, with end-stage renal disease, such as diabetes and hypertension, as these are, untreated, even in our safety net hospital? I don't know if there's if Dr. Yu or Dr. Ramos want to comment on any that point.
Yeah, sure thing. So, I mean, as I mentioned, these patients are sent to us after a lot of times after they've already started dialysis elsewhere. Um, Unfortunately, they don't have access to preventative care, right? Uh, they are a lot younger than our documented patients that start dialysis who have received some form of preventative care and have had some form of doctor see them at some point in their life. Most of the undocumented patients just show up, and unfortunately they're far gone. So I wish I had an answer and a solution for that. Then we wouldn't be talking about this topic. And I think that if they had healthcare access, they'd be able to get preventative care and avoid the dialysis initiation, sort of. But absolutely agree, if we could avoid it, that'd be the best thing.
Yeah, again, in terms of access, where as vascular surgeon, as we saw the results, once they reach us, I think in terms of once they get access, the maturation and so forth, but we're down the line in terms of is access to preventive care, access to those things that I think leads into the whole disparity, the whole discussion, preventable health and all of those things. Another question here from Dr. Kernodal. I apologize again. Very important work for those that are interested in terms of improving outcome for vulnerable populations. Can you elaborate on the challenges of capturing outcomes of patients that are undocumented? About 25% of the initial population did not have long-term follow-up. Any thoughts about how that might have biased the results?
Yeah, so I don't. It really was, if they didn't keep dialyzing with us for more than 6 months, we couldn't say include them in our analysis. So they would either go to a different hospital, leave the state, or return to their home country, right? We don't know what happened to them. That's also the problem with these patients, that, it's not like they come to dialysis, to our through our emergency department, but we're not their dialysis unit. They can have the right to go anywhere else. And our healthcare or our EMRs is only as good as it can be. We do have Epic, and we could see some care everywhere. But if other places have other EMR, EMRs, then we're not going to be able to track them. So if we didn't have good follow-up, we weren't able to compare them and include them, which is why we excluded them. The state only includes about 60 patients, and like I said, we have about 120 patients in our dialysis units on a weekly basis.
This has been really excellent discussion, and unfortunately, we're just a little limited with time, so I do need to move us on to the next paper, but there are still some additional questions in the chat, so if the authors and presenters want to respond to those questions in the chat, that would be wonderful. Our next paper is going to be presented by the team from Northwell Health. Validation of non-home discharge risk score after elective intrarenal bypass surgery. Speaking of access, I think Dr. Slope was stuck in an AV fistula, but hopefully is on now and can lead us off with some background information.
Hey, thanks so much for having us. Yeah, I'm here. I apologize. I missed the first few minutes. I got stuck in the operating room later than expected, as typical for Northwell Health. But really, I think my intro to this is more of an op-ed. There's not too much literature on this, and this is why this is such an important gap for us to kind of address. Anecdotally, my practice is a lot of PAD, a lot of CLTI, and limb preservation, and so as such, I do a lot of bypasses. And this kind of really hit home, this article, because almost majority, I mean 98% of my patients probably end up going to a non-home discharge, a skilled nursing facility, subacute rehab, or acute rehab. And I mean, that really impacts everything, right? From patient care, patient complications from surgery, wound healing and wound progress, wound care. But on top of that, as many of you on the call probably also experience, we get dinged all the time for our excess days. And so, one of the things that discharge planning, one of the problems that creates for us, is that the patient stays in the hospital for a lot longer than they need to following their lower extremity bypass surgery. And so we've actually recently been talking, and this is why this is such a relevant article, I think, in my opinion, is we've recently been talking so much with discharge planning, trying to figure out, when in the hospital stay, can we start the discharge planning process? How do we identify patients that really will need rehab, and kind of work towards getting them to a non-rehab or to a home discharge plan with physical therapy, outpatient, or in house. And the paper, I think, is excellent. Obviously, Dr. Grace Yu is going to go into it a lot more in detail. But what it points out is the fact that every patient that gets discharged to a non-home facility really increases the risk of patient complications from surgery, the cost of the healthcare system, and from just as someone who does these and discharges these patients all the time, it really creates a lot of havoc in the attending surgeon's life, because not only do they have to manage the patient now as an outpatient post surgery, but they really have to manage expectations for the patient's family, as well as deal with whatever wounds the patient might have. And you're not obviously the wound care doctor at the facility who's treating these patients. And so, I think that this is a perfect paper to kind of start the conversation to address a lot of these issues. Obviously, this was a scale that was previously created, but not really validated with any external data set. And so, this paper, I think, did a very good job at addressing that. And I'll kind of give the floor to Dr. Grace Yu and let her tell us what the paper said.
All right.
Well, hello, everyone. My name is Grace Yu. I am a newly minted PGY4 at Northwell Health. and I'm very excited to talk about this paper with you guys. So this presentation is going to review the article Validation of Non-Home Discharge Risk Score After Elective Infrainguinal Bypass, published in JVS of this month, out of UCSF. So I thought it'd be fitting to kind of first start the discussion by talking about why non-home discharge is an important topic. So non-home discharge means that the patient cannot be discharged home safely after an operation and instead goes to a facility, usually a rehab center or a skilled nursing facility. Post-op discharges to rehab and skilled nursing facilities are associated with worse outcomes, including more complications, hospital readmissions, and loss of functional status for patients. Financially, post-operative care is expensive, and non-home discharge represents a significant financial burden. The article mentions that Medicare spent over $27 billion on skilled nursing facilities in 2023 alone. Patients undergoing lower extremity bypass often have comorbidities and advanced disease, leading to relatively high non-home discharge rates and resource needs. So ensuring a safe discharge for these patients is challenging yet critical. Aside from metrics itself, a non-home discharge often means a patient loses some level of independence when they fail to return home, which can impact their quality of life. And I think all these factors briefly underscore why predicting and potentially mitigating non-home discharge is important. So the best way to tackle non-home discharge, I think, is to predict which patients are at risk beforehand. Because non-home discharge is linked to poor outcomes, if surgeons can know ahead of time that a patient is likely to need rehab, they can adjust care plans and counsel patients accordingly. So recognizing this, prior researchers created risk models. The Vascular Study Group of New England developed a novel risk score based on their database to predict the likelihood of a non-home discharge following lower extremity bypass, or LEB, for peripheral arterial disease. That score used preoperative factors to categorize patients into low, moderate, or high risk for non-home discharge and showed good predictive ability. There are also general frailty scoring systems that I'll talk about here, like the Modified Frailty Index and Risk Analysis Index, which correlate with adverse outcomes, including non-home discharge. However, a score that's tailored to lower extremity bypass might be more precise compared to these general frailty scores. And until now, that lower extremity bypass non-home discharge risk score hadn't been validated outside its original setting. So the rationale for this study was to perform an external validation, essentially asking the question, does the score work in a different hospital's patients as well as it did in the original study? So this study's primary objective was to validate the lower extremity bypass non-home discharge risk score externally. They took the risk model from the prior study and tested it in a new set of patients to see if it still works. The hypothesis was that it would work, that it would accurately predict which patients ended up in a skilled nursing facility or rehab versus home. I think importantly, they also included a secondary analysis comparing the lower extremity bypass specific score to generic frailty measures in terms of predictive power. And since frailty indices are commonly used to gauge patient robustness, I think it's useful to know if a tailored surgical risk score adds value beyond general frailty measures. So the underlying hypothesis here is that a procedure-specific tool might be accurate, might be more accurate compared to a one-size-fits-all model. So in terms of study design, this was a retrospective review of patient records at a single high-volume quaternary care hospital. They pulled data on all elective infrainguinal bypass surgeries between 2012 and 2020. Importantly, if a patient died before discharge, they were not included in the analysis because the focus of this was discharge disposition among survivors. The primary outcome of a discharge to a facility was determined from the hospital discharge records and mirrors the definition used in the original risk score study. And all relevant preoperative variables for the risk score were extracted from the electronic medical records. So the slide is a little bit dense, but I was trying to break down the lower extremity bypass non-home discharge risk score itself. It's an additive point score using 6 pre-op variables, and this slide lists each factor and the points assigned. So some key points is that age is heavily weighted, reflecting a much higher non-home discharge risk with advanced age. Female sex and non-white race are also risk factors in the original model, likely serving as proxies or factors like proxies for factors like frailty or social support. Poor ambulation is another big factor. Insulin-dependent diabetes and anemia also each contribute 2 points, likely representing systemic disease burden. And if the patient had tissue loss, that would add an additional 3 points. So they summed all these to get a total score. And in the cohort for this study, the score ranged from 2 to 14, with a median of 6, meaning a typical patient had a moderate risk. As defined in the original study, a score of less than 5 was low risk, a score between 5 and 9 is moderate, and a score greater than 9 is high risk. So they applied these same categories to stratify the patients. So in terms of the analysis, they checked how well the risk score predicts non-home discharge in this new data set. They ran logistical regression to quantify the association between the risk score and the outcome. One of the results that they use is the C statistic, or AUC, or area under the curve, which tells us the model's discrimination. 1 would be perfect and 0.5 would be no better than chance. Interestingly, they also did a Hosmer-Lemeshow test for calibration. And this test examines if the predicted probabilities align with the observed frequencies across risk deciles. A high p-value indicates that the model fits well, or that there's no large deviation between the predicted and actual outcomes. And then they plotted the observed versus predicted non-home discharge rates for each score to visualize the calibration, which I'll show in a figure later. They also looked at the risk categories explicitly, how many in each category had non-home discharge and how much higher were the odds compared to the lower risk group. And as I mentioned before, I think importantly, they didn't
What?
stop at the lower extremity
Oh,
bypass
no.
score itself. They also calculated a modified frailty index and risk analysis index for each of these patients. And then all analysis was done using standard statistical software. So in regards to results, let's first get a sense of the patient population. There were 241 patients in the analysis. They initially had 242, but likely 1 was excluded or missing data. The average patient was 69 years old. About 1/3 were women and 1/4 were non-white race. In terms of why these bypass were done, roughly 4 in 10 patients had rest pain. And roughly another 4 in 10 had left-style limiting claudication, so a mix of severe and moderate PAD cases. I think importantly, 22% of these patients did not go home. They went to a skilled nursing facility or rehab. That's about 1 in 5, which I think is quite significant. Most went to a skilled nursing facility, and only a few required acute rehab. And when they looked at factors, or when they looked at which factors were associated with non-home discharge, just 1-by-1 analysis, they found 3 that stood out: older age, tissue loss, and anemia. And then in the multivariate model that included all the risk score variables, age and anemia were the 2 that independently predicted non-home discharge. So I think that the lower extremity bypass non-home discharge risk score performed well in this external validation. The distribution of scores in this cohort was 2 to 14, which was similar to the original study. And importantly, patients with higher scores tended to end up in facilities more often, which is what we anticipated we would see. Quantitatively, the model's discrimination was good. They had a C statistic of 0.702. And in clinical or risk prediction, I think 0.7 is generally considered good with a moderate level of accuracy, certainly much better than chance. And calibration-wise, the model did not show any significant miscalibration. The Hosmer-Lemeshow test was comfortably non-significant with a p-value of around 0.75, implying that the predicted probabilities are quite in tune with the observed outcomes. And so looking at the discrete risk categories, we see a clear gradient. Low-risk patients had a very low non-home discharge rate at around 10%. Moderate risk was around 20 to 25, and a high risk around 1/3 or 33%. And then in terms of logistical regression terms, being moderate risk versus low risk was associated with 2.5 to 3 times higher odds, and high risk versus lower risk about 4 to 5 times higher odds. So this figure illustrates the model's calibration. On the x-axis, you can see is the risk score from 0 to 14. On the y is the percentage of patients with non-home discharge. The blue line is what actually happened in the studies cohort, and the green is what the model would have predicted. And we can see that these models match pretty well to give us a well-calibrated model. So in terms of the secondary analysis asked, the question of how the study's focused risk score compared to more generic measures of patient frailty. And I think there was a logical correlation. Patients who scored higher on the lower extremity bypass score also tended to have higher frailty scores and vice versa. So I think to interpret these results in context, first, the primary goal of external validation was achieved. The lower extremity bypass, the risk score worked in a new environment, giving us confidence that its results are not confined to one data set. We saw that age is a dominant factor, probably captures a constellation of geriatric issues as we age, mobility, cognitive function, etc. I think interestingly, while the original score included female sex and non-white race as minor risk points, we did not find these to be significant predictors here. I think, it could be simply that this study wasn't powered to detect those, since less than 40% of patients were female and less than 30% were non-white. Or perhaps these factors are context dependent. It's possible that the original large registry found small statistical effects of sex and race that aren't apparent in a single center group. In any case, in this data, being female or of a certain race didn't notably change discharge outcomes once you account for clinical factors. I think I also noticed a curious trend with Hispanic patients having fewer non-home discharge scores. The authors suspect that this is largely an age effect. The Hispanic patients in this cohort were younger in age. But given the small number of Hispanic patients in general, 29 total, only 3 had non-home discharge, and I think it's important to not overinterpret this. And then another important point from the discussion is the value of a procedure-specific risk model. So this study really confirmed that this lower extremity bypass non-home discharge risk score did a better job than generic frailty scores in pinpointing who needed facility care. So it's important to address and acknowledge the strengths and limitations of this validation study. On the positive side, the fact that this is an external validation is a major strength in and of itself. I think many risk models never get tested outside of their birthplace. So demonstrating that the score works in a different population, different geography, possibly different practice patterns is a big strength. Clinically, the score uses variables we always have on hand: age, basic labs such as anemia. We don't need any crazy or exotic input, which means that most vascular surgeons could potentially apply this scoring system in the clinic or preoperatively. The outcomes we saw were in line with the original study, which gives us confidence that the patient cohort was comparable and that we're dealing with a similar scenario in terms of discharge challenges. However, in terms of limitations, this was a single center study at an academic quaternary care hospital. The results may not generalize to, say, smaller community hospitals or different patient populations. And with their patient size of 241 over 8 years, it may limit statistical power as well. And I think also with retrospective data, we tend to rely heavily on the quality of documentation. And so this could induce some bias. And another limitation is that the study only looked at the factors that were in the original score. I think perhaps there are other important predictors of non-home discharge, like cognitive function, social support at home, which weren't evaluated here, that could be assessed. So I think to conclude, this validation confirms that this risk score is a valuable tool for vascular surgeons. We have evidence now that it works outside the original study, providing a reasonably accurate prediction of whether a bypass patient will need a non-home discharge. The score's strength lies in its simplicity, just a handful of factors, and its specificity to the patient population, which likely contributed to its better performance compared to generic frailty scores. I think in terms of future directions, the authors and, I foresee several avenues. Firstly, a prospective validation is essential. The current validation was retrospective, but doing it prospectively and tracking patients in real time and seeing if the model or the predictions pan out will remove some biases that can better simulate clinical use. I think next we should try and integrate the score into routine practice, likely via the electronic health record. I think perhaps a real-time calculator or risk flag could be built, and we can ask the question if knowing the risk score early can change the outcomes, maybe by prompting early physical therapy or different disposition plans. And then I think also there's room to refine the model further. The current score was constrained to variables available in the original data set, mostly basic demographics and health conditions. And we might be able to enhance accuracy by adding other predictors. And then another angle is validating the score in diverse settings. Maybe the score works differently in a rehab-rich urban area versus a rural area where a skilled nursing facility access may be limited, or in populations with different social structures. And then I think finally, non-home discharge risk is not just an issue for lower extremity bypass patients. I think this article references similar risk models being developed for aortic aneurysm repairs. And over time, we might integrate these models and have a comprehensive risk assessment for any vascular surgery patients post-acute needs. And so, yeah, thank you so much for this opportunity to present this paper, and I'll open the floor for discussion.
Thank you so much for a great presentation. We have the first and senior author from UCSF here with us, as well as Dr. Kernodle. I just want to brag / market for JVS a little bit. Dr. Kernodle is a trainee still. We usually don't have trainees on as the expert discussants, but she is an expert and was just named the JVS Rising Rising Star Peer Reviewer, which is an awesome accomplishment. And I know she participated in the JVS internship, which allows trainees the opportunity to participate in and learn the peer review process, which has been really rewarding for me and many of us on here. So any trainees, make sure you look out for that opportunity. I think this year's application just closed, but with that, I will turn it over to Dr. Kernodle to lead some discussion.
Great. Thank you so much, Libby. Thank you to the authors for a very timely and relevant manuscript. I think that our profession is under a little bit of scrutiny right now as we think about how resources are allocated, thinking about value-based care and thinking about the patients that benefit most from our interventions that can be a long road for some patients. My first question for the authors and the presenters, in thinking about some of the risk factors that are a part of the score, the existing score, I think that they include a lot of things that we kind of have a bedside test for. We do some mental math when we see a patient. Are they old? Are they frail? How much tissue loss that they have? And we kind of have our own estimation of what the recovery and post-op is going to look like. I'm curious from the authors and also the presenters, how do they anticipate that the score, should be used in clinical practice? I loved, there was a comment in the discussion, talking about future directions and, whether or not presentation of the score, for example, would change patient decision-making. But I'm also curious on both the provider and patient side, how would you like the score to be used? And what do you think is next?
I'll start off. Hi, everyone. My name's Elizabeth. I'm really grateful to the JVS and the Young Surgeon Society for considering our manuscript and allowing it to be discussed among the group. And thank you, Dr. Kernodle, for the first question. I think, as you said, the components of this risk score are readily available and something that can be easily assessed and aggregated to form sort of a numerical picture of what things that a patient might be considering for their post-operative needs. And I think ideally, what we would be seeing this score in clinical practice would be at something like a preoperative clinic visit. These were all elective surgeries, and so these patients have already met their surgeon. And so what we're trying to do here is to allow surgeons and patients to plan together in the preoperative period about what things they can anticipate postoperatively. So having a risk score on hand as a clinical decision tool can help patients decide how long they need to schedule out the surgery to do things like prehabilitation, working with physical therapy, or in sort of the more perioperative space, maybe there needs to be more discharge planning with case management for patients that we already know, based on their score, need more support after discharge.
Yeah, I'll just add first, I want to thank the JVS for reviewing this paper and talking about it. I really appreciate that, and really well presented by Dr. Yu. Thank you very much for that overview. I also want to point out that student Dr. Raby is a fourth-year medical student who will be looking for vascular integrated residency spots coming up. So keep an eye out for her. She's a rising star. I think this study is really the start of the conversation, not the end of the conversation, right? I mean, I think in the last 5 years from when I published the first study to this one, the acceleration of understanding about the importance of age-related conditions and the discharge process has accelerated. Just to give a shout out to Dr. Arya at Stanford and her work using the RAI, they're now implementing that process within the VA in a clinical trial called surgical pause that they're trying to roll out nationally at the VAs, in which if you score, I believe it's a 37 on their clinical RAI, you should be considered for multidisciplinary evaluation. And I think that really is underlined by the importance of geriatric syndromes. And that's probably why this score is really heavily weighted on age. I don't think age is a really great metric in and of itself, to your comment about sort of the gestalt that we give. And in fact, when someone asked me what's your favorite frailty score, it was the when you look at the patient, do they look frail? When you have them get them on the bed to examine them, like, are they able to do it? And Dr. Coyer, formerly at Michigan, now I believe at OSU, did some great stuff using videos showing that actually is a really great test of frailty. But I think we need to move more towards what the age-friendly system and the IHI has suggested, which is the 4 M's: mentation, medications, mobility, and what matters as the important things to focus on, or the geriatric surgical verification program at ACS, which really talks about these geriatric syndromes like risk for delirium, dysphagia, urinary incontinence, depression, overall cognitive impairment. Indeed, we've done studies looking at cognitive impairment, demonstrating that increases risks for non-home discharge. Similarly, we've looked at depression, which increases risk for non-home discharge 50%. So there's a lot of these things that I think are tied up in the sort of aging syndromes that are really important. But the sort of way I see this playing out is doing better screens at the outset when we first see the patients. These screens will allow us to better talk to our patients about the potential risks. As a matter of fact, the risk of going somewhere else other than home sometimes to my patients is the most important factor. If you say, hey, look, there's a really strong chance you're going to go to a nursing facility, like, you know what, I don't really want surgery that bad now that you mention it. And so that independence is so key to patients. So I think this is an important, I think this study is important to highlight that needs to be part of your discussion, and you need to be thinking about that. And when people screen positive, whatever way we want to screen for it, I think we need to really think about creating multidisciplinary approaches to help optimize their care. Obviously, non-home discharge is just a piece of that. These patients are at high risk for all sorts of complications, and going to a non-home is just kind of one piece of that, demonstrating a more complicated course.
Great, thank you. I want to encourage everyone to drop some questions in the chat. I do have another one. I'll keep going, but I'd love the group to also contribute. So the second question that I have, just thinking about the scientific premise of the paper, and that non-home discharge is associated with healthcare costs and bad. I feel like I meet some patients that I want them to have a short course of rehab because I know they're going to get better PTOT. I know they're going to get better wound care. And also, I've witnessed some practice variation. So, I'm currently training in Boston, and the patients here have excellent VNA, almost, better than what they get in the hospital. And so if I'm sending someone home with, a wound, or to rehab, or to a SNF with a wound, or to home, I have like great faith that it's going to, do well, as compared to, where I trained in residency when access to good home care was variable. So I'm curious, number one, about the granularity of the data in terms of what happens at a SNF and after a SNF. And if you think like some further stratification of that outcome would be helpful to understanding what happens to the limb preservation population.
Yeah, thank you so much for your question. And I appreciate the point that non-home discharge is not always a bad thing. I think there's a lot of patients that benefit from sort of around-the-clock support and intensive nursing care that they couldn't get at home otherwise. And I think, again, it's important to recognize that. And I think what this score does is it recognizes patients that might be in need of this extra support, so we can plan for that and get them set up with the best possible extra support that they need. As far as like long-term data on how patients are doing, we don't exactly know which skilled nursing facility within the Bay Area that patients went to, but we know that at 1 year, we had, sorry. At 1 year, 88% of the patients were living at home. And 92% of those patients were all still living. So while patients might not go home right after their surgery, that doesn't mean that they will never return home, which is reassuring. And again, it speaks to the fact that some patients really do benefit from that intensive rehabilitation. And I think, again, granularity is really important. With a bigger data set, it might be even more beneficial to track particularly which patients are doing better with these non-home discharges and which patients are not doing as well.
Yeah, so I'll just comment that when I did this first study, I was in Boston myself, and where this really came from was the pain point as a fellow going in to see a patient, someone who, you know, to your eyeball test comment earlier, clearly looked like they were going to need a nursing facility. And you bring up the fact that, hey, look, you might need to go to a nursing facility after this, or acute rehab short term. And like the patients being totally blindsided and being like, well, no one ever said anything about that. I don't want to go anywhere else. And it taking a day or two for them to even agree to think about a nursing facility. And then that taking, you know, adding on another day or two, maybe 3 to their discharge process, could be even more if this is going on a weekend, right? Because no one ever talked about it or thought about it. So I totally agree. Going to a nursing home isn't bad, but it is a conversation that needs to be had and patients need to be prepared for. Like you said, hey, look, it's going to be hard for you to take care of your own wounds. You might want some help, and having that kind of conversation. I love your idea of kind of looking more granularly at what happens, particularly people in like the high risk group. Like if you were predicted to go to a nursing facility but didn't, was your outcome worse? Like, should you have gone to a nursing facility? Would that have resulted in a better outcome? You know, one of the other geriatric syndromes is social isolation, right? So these people don't necessarily have the help that they need when they go home. Some may not be getting them groceries. Some may not be able to help them with wound care. I work at the VA, and a lot of these people don't want help, and yet they really, really need it. So I think those are great points and things to think about.
This has been amazing discussion overall tonight. I really appreciate everybody's insight. I am pretty sure that JVS editors are gonna kill me if I don't cut it off soon, but please reach out with other questions. I'm sure the authors, presenters, moderators would all be happy to answer questions or have further discussion. Thanks again for attending tonight. Remember, the next JVS Journal Club is on August 13th at 6 p.m. Central Time. And a few people have been reaching out to me while we're on this, asking how can you get involved with this? If you want to be involved with JVS Journal Club, there is a call every year, but if you want to specifically be involved with the Young Surgeon Section 1, Dr. McGee and Dr. Sen, who are online, are currently the co-chairs of the YSS Research Committee. I'm retiring, but if you would like to reach out to me, I will also help put you in touch. And if you want to be involved with YSS, there is a research work group that we have published some papers and done some things like this JVS Journal Club, and we'd love to have you on the work group as well. So with that, thank you all so much and have a great night, and hopefully we will see you next month.
Yes, excellent. Thank you, everyone.
Thank you, everyone.
So
Great
much.
presentations.